And we are live.
Good morning, everybody. Welcome to the fall 2021 group meeting of the SWOG Symposium. Welcome to the Jeri and Noboru Oishi Symposium. My name is Christina Bueg. I'm a member of the SWOG Research Committee for ORP. Just a brief rundown of our agenda today. From 10 to 10:15, we have announcements by me. At 10:15 to 10:45, we're privileged to have Amanda Fournier from CTSU give us some updates about some of the changes at CTSU. And at 10:45 and 11:15, we have Dr. Heather Greene, who's going to talk to us about some of her very important work on integrative medicine and clinical trials. Immediately following Oishi this morning, we'll be leading straight into open forum. And so we very much encourage you to stick around, and it'll be a really excellent presentation. Next slide, please. We always like to begin Oishi by acknowledging the very generous work of Dr. Noboru Oishi and his family, who have long supported the Hope Foundation and SWOG in the work of cancer research, particularly in support of ORP. Next slide, please. What is ORP? So ORP stands for Oncology Research Professionals, and bottom line, it is all of us on the line now today, all the research nurses, research coordinators, all the data managers who do the groundwork to get these protocols done, the lab draws, the data entry, the protocol implementation, the regulatory pieces. Is really critical that our voices are heard and we get involved to make sure these clinical trials are as effective and as implemented as the way they're supposed to be. There are a number of different opportunities for involvement. We'll run through them in a second, but if you have any questions at all ever, please email us at orp@swog.org. Next slide, please. What is an ORP liaison? So the liaisons play a critical role in making sure that the voices and opinions and insight of ORP is communicated to the study coordinators, the protocol chairs, the study chairs, and SWOG in general to make sure that what we see on how to run a protocol is implemented. So we encourage everyone, if they'd like to, become an ORP liaison and have your voice heard. Next slide, please. Here on the slide, there's some current ORP liaison positions, disease-specific positions. Please take a look at them. And if you have a particular interest or expertise, we encourage you to reach out to us, and you get a chance to sit in on those committees during protocol development and really give your opinions on what are the nuances that really make or break a protocol. A time commitment, at most about 60 minutes per month. Maybe it's 15 minutes a week, depending on where we are in the protocol cycle. We also have at-large liaison members who don't sit on a specific committee, but have their voices heard across a number of committees. And perhaps when there is a specific committee opening, then they'll jump into that role. Seal and Sandy Annis are listed here as the chief contacts. And again, if you have any questions, orp@swog.org. Next, please. I want to go over some of the key resources on the SWOG website. Next slide, please. First, on the ORP main page, if you go to the far right under member resources, there's the ORP link, so follow that. And next slide, please. And a big announcement, we have now a SWOG.org clinical research resources website, one-stop shop for all the things that we need to do our job, the regulatory pieces, the credentialing pieces, public access training, online resources, continuing education. So this is a really excellent development, and it's in its infancy, but we encourage you to go there and really make use of the resources. Next, please. We also have resources on the CRA workbench on the far left, and we encourage you to check out the newsletter that's on the far right of the CRA workbench. Also, the SWOG ORP manual. If you haven't been there, please go and take a look at it. The SWOG ORP manual is written by ORP members for ORP members, particularly useful for training new staff on what's involved in running a SWOG protocol. Next, please. Speaking of the newsletter, if you have not yet subscribed, please go to CRA newsletter at crab.org to get on that membership list, and it's published quarterly. Next slide, please. one day we will get back to in-person meetings. And if your site needs travel support, we encourage you to go to the CRA Nurse Travel Support Program at the Hope Foundation to see how they can help you with those travel expenses. Next slide, please. We also have an important announcement about upcoming site operations survey coming out in November. Your feedback is critical in making sure that what we see on the ground level about how to implement a protocol is communicated to SWOG. So look for that site survey in November. Please complete it and send it back. We really want to hear what your voices, what your opinions are. Next, please. Now, I wanted to discuss briefly an important work by NCORP on increasing diversity in our clinical trials populations. And next slide, please. So there's an NCORP pilot grant program, and there's a link there to follow. And they are seeking they're seeking to give $50,000 in funding for 1 to 2 year projects to test unique strategies that your site might have already implemented, and we can take to a larger scale to increase diversity in our clinical trials population, so to make sure it really represents the diversity in our community. So if your site has done something great already, please apply for one of these grants so that we can test it and carry it to the larger scale. Next slide, please. If you like some more information about it, the applications are available on the NCORP pilot program website. The foundation, the Hope Foundation, is supporting us. Next slide, please. As well as Genentech. If you like more information, please check into the office hours tomorrow, Thursday, October 14th, from 12 to 1 Central, and to learn more about this grant, or email Morgan at thehopefoundation.org. Next slide, please. Now I'd like to turn it over to Jamie Myers to talk about some very exciting developments on advanced practice practitioners. Jamie?
Thank you, Christine. Good morning, everyone. I'm Jamie Myers, and with me this morning is the newly minted Dr. Krista Brown-Inglis, who recently completed her DNP. We are here from the Nursing Research Subcommittee to share some exciting news. Many of you likely already are aware, but we wanted to take a few moments to celebrate further evolution and policy developments since the spring meeting. This specifically relates to advanced practice provider rules in our clinical trials, and we want to say a special thank you to Andrea Danikoff and Marge Good for championing these policy changes within CTEP and DCP. Next slide, please. One of our big gaps in leveraging the power of advanced practice providers was the need for investigational new drug orders to be co-signed by a physician. This new policy allows qualified advanced practice providers to order study agents, including IND agents. To do so, the APPs must be rostered as non-physician investigators, added to the Delegation of Task Log to the task of IND prescribing, and the site clinical investigators must sign the DTL for the qualified non-physician investigator to conduct this task. So the Advanced Practice Society for Hematology and Oncology definition for qualified APPs is listed for you here. And I'm very excited to say that this policy broadly covers a variety of NCI trials. So sites do need to have institutional policies in place, including appropriate credentialing processes consistent with the local and state laws for scope of practice, as well as a statement regarding physician oversight. So I'm not going to get too granular this morning because you're going to be hearing more specifics about this policy change this morning from Amanda Fournier and in other settings during our fall SWOG meeting. But we're really excited to celebrate this development with you that will enhance and strengthen the ability of APPs to take a more active role in supporting SWOG research. And at our Nursing Research Subcommittee meeting later this morning, we're going to be discussing ways that we can measure the impact of this new policy. Thanks for the opportunity to share this, Christine.
Thank you, Jamie. Okay, next slide, please. So I just want to take a brief moment to acknowledge all the members of the ORP Executive Committee and everyone who has put in so much work to make this meeting and the work of ORP and SWOG to be so pivotal and critical to the success of our clinical trials. And I thank all of you joining us today, and we thank you, look for all our speakers and look forward to a great session today. And with that, I would like to take a moment as we transition slides to introduce Amanda Fournier from CTSU, who's going to be introducing some very important implement changes at CTSU. Amanda, thank you.
Thank you. So can you go to the next slide, please? So our agenda is going to cover three topics today: the adverse event integration between RAVE and CTEP errors, the redesign of the protocol-related documents on the CTSU website, and the delegation of task log improvements. So there are changes associated with each of those items, and we'll talk a little bit in detail about what those changes include. So you can go to the next slide. So let's first talk about the serious adverse event integration and the procedural change that we have just implemented in September. So next slide. So as most of you probably already know, on September 20th, we turned off the ability of sites to what we're calling direct reporting and CTEP errors, meaning if the protocol is an integrated protocol, you now are mandated, or dare I use the word forced, to use the integration, and you can no longer bypass the integration and go directly to CTEP errors. This is pretty well understood when you're trying to create a new adverse event report, but it gets a little bit convoluted when you're talking about amendments, specifically amendments that may need to occur on a report that was generated before September 20th and may have been direct reported in CTEP errors, and also amendments that would be on adverse event reports that would had occurred using the integration. So let's look at item number one. So an amendment would that includes changes made to data on the AE form, and this gets very confusing for a lot of folks. What are we passing from RAVE to CTEP errors during the integration? Well, pretty much everything that's on the AE form. So when we're talking about amending an already existing adverse event report in CTEP errors, what we're really talking about is, are we amending adverse event data, the routine adverse event data from RAVE, or are you maybe amending information outside of that data? It could be you want to amend a narrative, or an other cause, a prior therapy, a medication, a lab. There's a lot of information on the CTEP errors report that has nothing to do with the data that is collected in RAVE for a routine adverse event. So if sort of isolating those two things, I'm making an amendment and I want to amend something that was passed from metadata RAVE, then we're asking that you would need to use the integration. And the reason why is because the only way to pass any changes that are made in RAVE to CTEP errors, you have to go through the integration. If the change is made to something like the narrative or another cause, you want to amend a lab or a medication, theoretically, you could go directly to CTEP errors. So this is where it gets confusing, because I just told you we're turning off direct reporting of CTEP errors, not for amendments. When it comes to amendments, the original report already exists. So everything is going to be in your My Submissions tab or in your reporting tab in CTEP errors. And you can always amend directly in CTEP errors. If you use the integration, however, it takes you directly to a patient. Let's see if I can improve my audio here just a little bit. If that's any better. So if you're using the integration to start the amendment, it will take you directly. Oh, no improvement. Okay. Any better? Audio any better? Okay. Okay, thanks, Jen. So coming directly from the metadata RAID will take you directly to the CTEP errors through the patient. So it's the easiest way to get to your actual ticket. If it might be beneficial for me to switch to another audio. Okay. Any better? Am I still breaking up? Any better? Am I still breaking up? Still muffled.
Hi, this is Christine again. Amanda's having a little bit of a connection problem here, as I'm sure that we all have had moments like that, with the weather especially. So I'm going to continue on her slides for a moment here while hopefully she can reconnect. So the procedural changes for CTEP errors, as Amanda was talking about, again, the critical pieces are that we go through the integration as much as possible. And if you have a element of a amendment that needs to be made, we ask you to go directly through the to RAVE for two reasons. One, if
So, Christine, can you hear me better now?
Yes, I can. That's great. That's great. I will give you back.
All right, thank you.
Jay,
So,
can you mute me, please? Thank you.
All right. So just to summarize this, and then we can move off of this slide. But amendments, when you're doing amendments, we recommend that you come through the integration, whether the amendment is to data from RAVE or whether the amendment is for something that was not in RAVE. Either way, the integration will get you directly into the CTEP errors report to start the amendment, which is much easier than going through My Submissions or their report tab in CTEP errors. So moving on. So why all of this mandating of the use of the integration? Well, when we developed the integration, it was really to reduce the duplication of data entry. You've got two systems, you've got RAVE and CTEP errors, you're putting the same information into both. It was easier just to enter it into the first system and pass it to the second system. That reduced all of the reconciliation issues. And then the big one, which really came from NCI to set up the requirements of, let's reduce the amount of over and under reporting by evaluating the adverse events. So what we're doing is we're actually, when you enter the adverse events in RAVE, we send all of those adverse events to CTEP errors. They run it through the rules engine, and it comes back to RAVE with a recommendation, report or not report. And the nice thing is that these rules can now be standardized, and those rules are built for each protocol during the study build period. So, whatever rules are in the protocol should be now in CTEP-Airs. And so when you get that recommendation, you should be able to rely on it to help, decide, do I need to report, do I not need to report? So anyways, those three things alone could help us immensely in reducing the amount of over and under reporting. To go to the next slide. So a lot of questions came from the meeting that we had on September 9th when we told everyone we were going to turn off the integration, and that was, well, how do I even know if my study is using the integration? And we get this question quite frequently. And there's several ways to tell. One, if you're in RAVE and you're collecting adverse events, you're going to notice that for every treatment cycle, there's always going to be two forms, not just the adverse event form, but an accompanying form, which we call in the expedited reporting evaluation form. If you have an expedited reporting evaluation form, your study is using the integration. If you don't, your study is not using the integration. If you really want to know more succinctly, on the CTSU members website, there's two places where you can look up your specific protocol. And when you pull up that protocol, there will be a table. And in that table are all of the integrations associated with that particular protocol. And if you're using the integration, you'll have a little green check under that column called SAE INT or SAE integration. All right, so those are the three ways that you can easily tell if your protocol is using the integration. So to run the rules evaluation on the expedited reporting evaluation form, you can go to the next slide. All you need to do is check that box and hit save. It's that simple. There's all of the programming is built into that form. And when you check that box and hit save, what you're essentially doing is passing the adverse events from the AE form to CTEP-Airs, and what you're waiting for is to get a recommendation back. And you'll notice that there on the left-hand side of the screenshot, there's something called a report ID. And here, before we send anything to CTEP-Airs, you'll notice that report ID is blank. If this transfer of adverse events is successful, you will get a report ID back. That report ID will be unique, and it will be your synchronization ID between the two systems. So what I always tell folks is if you don't have a report ID, the two systems are not synced up. If you have a report ID, you know that they're synced up, and it's really that simple. So go to the next slide. So when the rules engine runs, you check that box, you hit save, the rules engine runs, and it usually takes 10 seconds or less, on average about 3 seconds. It'll come back with a recommendation, and your recommendations initially are going to be none or create. Once you've created and you make a change in RAVE, it can switch to amend or edit. And eventually, if someone withdraws that report in CTEP-Airs, you can get a recommendation to withdraw here. But the only ones that we really need to worry about here or concern ourselves with are going to be none, which means no report recommended, create, which means that a report needs to be initiated in CTEP-Airs, or amend, which means that a report has been submitted to NCI and a change needs to be made to the report. You'll notice along with the create here that it told the user that a 24-hour was, so the report type is going to be there, and also the due date for when that report is going to be due. And so on the left-hand side, oftentimes in very small font, unfortunately, we've not been able to change this, but there is a link from RAVE to CTEP-Airs. So you'll click that link and it will take you directly to CTEP-Airs for this patient for this cycle. Next slide. All right, so when you click that link, again, it would take you to CTEP-Airs. If you have a recommendation to create, like we had on the previous screen, then the investigator may decide, hey, according to the protocol, I don't really think this adverse event or adverse events with an S needs to be submitted to NCI. This doesn't look like it's reportable. You have the ability to change create to none, and you can do that on this screen. However, if the initial recommendation is none and you choose to go to CTEP-Airs anyways to create, it gets very confusing because you can't change none to create. And so then people ask me, well, how do I tell, my group or NCI for that matter that I want to report? Well, you're telling NCI that you want to report when you click on that link and you go to CTEP errors. And CTEP errors is going to ask you to override the none recommendation, and you can override and report. But it left that none sitting in rave, and this is always very confusing. What do I do with the none? And I have to tell people there's nothing you can do. Well, there is one thing you can do, and you could put a comment on the field here, this none field. You can always write a comment on that field just stating that the investigator has chosen to report even though you got a none recommendation. And that's really the best that you can do. Unfortunately. So we are looking into ways right now in future releases of this integration to give folks a way to notify us that they want to change none to a create. But for right now, there's no other way to do it other than to write a comment in the audit trail, which is very cumbersome, but that's the only thing that you can do. All right, next slide. All right, and then finally, problems, errors. So this is the problem with the expedited reporting evaluation form is, and the reason why a lot of folks have been direct reporting the CTEP errors is you enter your adverse events, you come to the expedited reporting evaluation form, you check the box, you hit save, and what do you get? You get an error at the top of the form. And errors can occur for a multitude of reasons. And what that error is going to tell you is the integration has failed. And you're going to be able to tell that the integration failed because there's going to be no report ID. You can see in this example on the screen, the report ID field is blank. And if the report ID field is blank, there's no synchronization between the two systems. CTEP errors doesn't know what's in rave. Rave doesn't know what's in CTEP errors. And you're left sitting there with your hands up in the air saying, what do I do now? And what we're suggesting now that we've turned off direct reporting of CTEP errors is just contact CTSU. Let's get this error resolved as quickly as possible. Don't waste any time. There are 3 help desks associated with SAE reporting. You have the AEMD help desk, you have the CTEP help desk, and the CTSU help desk. To make things easy, always start with CTSU. We will triage to another help desk if needed. But the idea is that we want to treat everything as if it was a 24-hour report, and so we want to get on it as quickly as possible. So go to the next slide. So this slide suggests some of the reasons why you may need to come to CTSU. I tell people this a lot, but there can be no queries on the adverse event form. It's going to cause the integration to fail. All the fields need to be filled out, especially the fields at the top of the form, which people oftentimes neglect because they're derived. Things like the treatment assignment code or TAC, the reporting start date, and the cycle number and cycle date. All of that information at the top of the form has to be completed. So when you get an error, you can always look to see, but again, you're not going to be able to resolve any of these errors on your own. So again, make things easy. Just come to CTSU Help Desk. We will do our best to get you moving forward within that same day. All right, we can move on to the next topic. So let's talk a little bit of the protocol-related documents on the CTSU website. Go to the next slide. So we are going to do something that is, we're doing actually with a lot of the items on the CTSU website, which is we're talking about a modernization. And you'll hear this term frequently. In really what we're doing, yes, the CTSU presentation slides will be available. We are going to be turning a lot of the items that are on the website into their own applications. Now, it won't change a lot of the interactions. You're still going to come to the CTSU website, but behind the scenes, a lot of these items are going to have additional features and ease of use because they are becoming their own applications. So one of the things that we plan to do with the documents is to improve the navigation to get to, specifically in this case, the non-CIRB documents, because there's a lot of different tabs, and I'll show you in just a second what that looks like. But we can definitely clean this up and make things easier for you to use. So if you go to the next slide. So this is what it looks like today. If you look on the left-hand side, you can see under the Documents tab, you have the CIRB documents, but then underneath of them, all of the non-CIRB documents, supplemental education, CRS, site registration, and so on and so forth. And each of those were tabs. So you have only one file on the left-hand side, one folder on the left-hand side that contains the 10 subfolders, and then you have the 10 tiles on the right, or 10 tabs on the right, that are really mimicking what's in each of those folders. So if you go to the next slide, we'll show you how this is going to change. So now what we're going to do is we'll keep the CIRB documents in their folder, but we're going to create a new folder that has all the non-CIRB documents in it. So now you can see that those 10 tabs or 10 tiles are now just everything is located in 2 folders, 2 tabs, 2 tiles, however you want to think about this. And so in order to improve the usability with this reduction in tabs, is you're now going to use something that we're going to include, which is this filter. So what's going to be new is this filter capability to drill down into a tab. So when you're in the protocol relateds tab, you're going to want to use the filter to drill down and find your specific related documents. So if you go to the next screen. So here is, you can see if you click on that filter, anything that you start to type, it's a smart filter. So as you type, it's going to shorten your document search. And you can see at the very top, as you type your search words, below that in the document title, it is shortening what is in that list based on what you're looking for, or what you're searching for based on your keywords. So that's how you're going to use the filter. And then you can see that in the drop down for the document type, it is nothing more than that list of, I think it's 9 items or something in that list. So you're going to see in that document type, you can filter directly for case report forms or site registration or patient enrollment. So you can, by choosing your filter, you can pretty quickly drill down or narrow down your search of what documents you're actually looking for. Go to the next slide. And then finally, we get to the download stuff. So we've included this download all. And download all is kind of confusing because it's not really download all. In very rare cases, people would want to download all. But download all is attached to the filter. So choose your format. A lot of people are probably going to want to download to a PDF. You could choose an image file, which is in this example here. But however, whatever format you choose to download to, once you've selected the documents that you've searched on, it may be you come up with 1 document or 2 documents. In this example, you can see the search resulted in 2 documents. Now, when you click download all, it's only going to download those 2 documents that are in your search, and it's going to download them to the format that you've chosen. If you really wanted to do a download all, then you would keep your filter clean, and it really will download everything that's in your original window. All right, go to the next slide. All right, so this is really just reiterating what I just said. So when you do the download all, it's going to download whatever is in your search window. And if there's everything in your search window, just remember, it's going to download whatever's in your search window. So the further you've drilled down and the more refined your search is, the more refined the documents will be that are getting downloaded. All right, go to the next slide. All right, let's talk a little bit about the delegation of task logs. So there is some improvements that are coming, and I'll just warn you up front, everything that's here is not in place yet. This is what is to be coming. So there wasn't a good way to show you because this is not in play yet, but just this is a heads up, FYI, this is coming. All right, so we talked a little bit earlier, Jamie talked a little bit about the advanced practice providers and what's coming. So Now we are going to be able to apply the non-physician investigators, those that are rostered, to the DTL. So now you will be able to, since the APPs can prescribe the IND medications, now you're going to want to list them on the DTL as under the prescribing task, and you'll be able to list them on the DTL. So again, this is all going to be preceded by the local laws, state and local practices, and if the site would have to have in place policies and procedures to provide this, to allow this. But assuming that the non-physician investigators can prescribe IND medications, then you now will be able to, with this new feature, be able to list them on the DTL, and they will be able to sign off as providers. So this policy has been updated in the Investigator's Handbook under the CTEP website. And if you go out there to this website, not only is the Investigator's Handbook out there, but CTEP has created a memo specific to the new policy surrounding the APPs. And I would highly recommend that folks go out to the CTEP website and read that memo. There's a lot of information regarding what the revisions to the policy are. And that memo was just released in mid-September, so literally a month ago or less than a month ago. So it's very up to date. So highly recommend folks go out there and read that. All right, so go to the next slide. All right, so a couple of other things. Again, can't really show you anything here, but this is what's coming down the pike, or what we're working on. So continuous dating on the audit history report. CTEP relocation status will to inactivate task assignments. DTL revision alert on the browser, and new administrative CRISP notification for task status changes. So these are requirements that we've gotten through feedback from various groups, and we are working on all of these requirements. These are, so the next slide, I'm going to show you some things that we're still looking for feedback on, but these are items that we've already gotten feedback on from groups, and these are things that people have worked. So the next release of this DTL modernization, if you will, is going to include all of these items. So if you go to the next slide. So these are things for future assessments, future feedback. So right now we are looking at metrics. And when I say metrics, you can see here, there's some examples, right? So the number of DTLs by status, number of DTLs per investigator and task assignment, DTL page hits. So these are things for us to sort of look at before and after the release of these bulk updates. That release went out on August 20th, and folks have been using this for 2 months now. So what we're trying to gather is, what we did back on August 20th, working, not working, in places where we need updates. And maybe more specifically, if you look at this next item, what we're looking to do is to survey sites on bulk signing and bulk actions. So we're going to release a survey. It says here late October, early November. Is more than likely it's probably going to be a month from now. So it'll be early to mid-November. We will post the survey to the CTSU website, and we will announce when it's available on the bi-monthly broadcast, and it will be open to anyone accessing the CTSU members website. So we're going to highly encourage folks to go out there and complete that survey. What we're looking for here is feedback on use of the current delegation logs and the signing, specifically regarding bulk signing and bulk actions. And what we're really looking for here is, we made some changes, and we did a release for bulk signing back in August. Are folks liking what we have? Your feedback is going to be extremely important on new features, future updates, and anything that's working, and especially anything that's not working. All right, go to the next slide. All right, so what we want to do, so finally we get to the DTL modernization. Really, this whole thing is about the DTL modernization, right? The next release is going to be this separate application that we're going to have for the DTL. So we want to improve the look and feel of the DTL, make it easier for folks to use, update the underlying structure, determine how best to implement the concept for a common site DTL. So one of the things we're going to be doing with the survey, along with the bulk signing is how is it defined and how would it work to meet all the sites? Has there been a discussion about implementing DTL features to RUMs? So I don't know, but we certainly can post that question internally to the CTSU group, and we should be able to get you back a response. All right, and then that was it for those 3 items. So Jade, I'll turn it back over to you, and you can.
Thanks, Amanda. I appreciate that. Thank you so much, Ed. Again, as we noted, we will try and make Amanda's slides available because I know that was a tremendous amount of really critical information that we'll need for our daily jobs. Again, Amanda, thank you to you and everyone at CTSU for making everything run. At this time now, I'd like to turn our attention to Dr. Heather Greene. Dr. Greene is an incredibly accomplished contributor to SWOG and cancer research in general across the country. She's going to talk to us today about her incredibly important work on integrative medicine and clinical trials. Dr. Greene.
Hi, everybody. Good morning. I'm Heather Greene. I'm really happy to be with you here today. I'm going to share my slides. And as we've all been experiencing, we hope that this works. And it's going to look a little weird. Oh dear. Why is this not working? Huh. Jad, it is not letting me share my screen. Okay, Jad, I'm going to send you my slides and see if you can do this. Is that okay?
Yeah, sure.
Can you put your email address in the chat? Sorry, everybody.
Well, Dr. Greene is working on getting that. If anyone has any questions regarding anything we've talked about this morning, please go ahead and type those into the chat, and we might be able to answer some of those now.
Okay, Jad, they're on the way. I'm not seeing any questions pop up, so I'm going to go ahead and just start talking about what I'm going to talk about I'll share with all of you today. So I am an investigator within SWOG, but what I'm going to talk to you about today is our integrative medicine program that we've set up here at the Seattle Cancer Care Alliance, and talk about some of the research that we do here, but also some of the research that we've done in other related to SWOG. So for many years, I was faculty at Columbia University, and that's where I started working in SWOG. And a little over 4 years ago, I relocated to the Fred Hutchinson Cancer Research Center in Seattle and launched a new integrative medicine clinical program at the Seattle Cancer Care Alliance, which is the clinical partner of the Fred Hutchinson Cancer Research Center, University of Washington, and Seattle Children's Hospital. And so I'm really excited today to talk with you about, I was asked to talk with you about how we've set up our clinical program, how that works here at SCCA, and then also how that interfaces with our research program, and hopefully with some new trials that we're bringing to SWOG. So Jad, did you receive those slides? Nothing yet. That's odd. I'm so sorry. I'm also going to send them, Christine, to you as well. So while we're hopefully getting my slides figured out, I'm so sorry. I'm just going to give you a little bit of background about why we're talking about this in oncology patients. So we know that for any of you who work if any of you talk to any cancer patient, most of them are going to ask you, okay, what else can I do besides my medical treatment to improve my odds of survival or improve recurrence outcomes, and also just make me feel better during treatment. So many patients are interested in using complementary and integrative therapies. We know that there's very high use of these therapies by cancer survivors in the United States. We now have over 17 million cancer survivors in the United States. And somewhere between 60 and 80% of cancer survivors are using some form of integrative complementary alternative therapy following cancer diagnosis. And this is not this is actually to a very large sum of money as well. Probably over $7 billion are spent per year on this across the United States. And so this is also having a financial impact. And so patients are wanting to use these to increase their survival, increase their efficacy of conventional treatments, prevent and treat side effects of conventional therapies, treat existing comorbidities, improve quality of life, decrease their stress. But really from a clinical perspective and from a public health perspective, we want to know what works, what doesn't work, and what's safe. And so that's a lot of the research that's driving, the impetus behind the research that we're doing, but also we're trying to, figure out clinically, how do we implement some of these practices? So Jad, have you received those yet? Or Christine, did you receive those?
Nothing has come in yet.
Wow. Let me change to a different.
So do you have the option to share your screen, or is it not popping up?
It's not. I can try again. It wasn't working. I can try again. It's telling me I need to go to my system preferences, so just bear with me for a second. It looks like it's blocked for some reason, and I don't know why. Christine, did you receive those slides, or is there somebody else? Is there?
Unfortunately, no, I haven't received them either.
I'm going to try to send them to Maggie and see if she and Maggie can get them. I really do have some good slides to show you guys. Okay, Maggie, I'm sending them to you now. Maggie got nothing. Okay, it looks like Maggie might be making some progress. Thank you, Maggie. Oh, you're a gem. Okay, so let's go to the next slide. Next slide. Okay, there we go. Thank you, Maggie. Thank you so much. Okay, so just so that everybody is on the same, using the same terminology, I like to start with some definitions. So what are we talking about for integrative therapies? So we have traditional therapies, which are really culturally based health practices. These are all of the therapies that we bring from our families, from our communities, from our neighborhoods. These are the things that we grew up using or our families used. Alternative therapies are therapies that are used in place of conventional medicine. And so in oncology care, sometimes we hear patients coming in to say, you know, I'm going to forego conventional treatment and I'm going to go to this alternative clinic. Sometimes they're local, sometimes they're in a different country. Complementary therapies are the therapies that patients use alongside conventional medicine. And the way that we think about them in our program is that these are often therapies that or modalities that patients are self-managing, or they're managing alongside or they're managing and getting the information on their own, or going to other providers outside of their conventional medical setting, and they're sort of juggling these things on their own. And what we're really striving for is integrative medicine. And so what I mean by when I use that phrase is that this is the evidence-based use of complementary and supportive therapies in conjunction with conventional therapies. And so these are the therapies that people are providing at the same time with their conventional therapies, in really focusing on the evidence-based practices that we think are going to improve outcomes. Okay, next slide. So what is integrative oncology? I'm involved in an organization called the Society for Integrative Oncology, and we wrote out our definition and published this a few years ago. So I'm just going to read it to you because, and I think it resonates with most people who are engaged with patient care. Integrative oncology is a patient-centered, evidence-informed field of cancer care that utilizes mind and body practices, natural products, and/or lifestyle modifications from different traditions alongside conventional cancer treatments. Integrative oncology aims to optimize health, quality of life, and clinical outcomes across the cancer continuum, and to empower people to prevent cancer and become active participants before, during, and beyond cancer treatment. So integrative oncology is a very large field. Next slide. So when I was brought in to build our integrative medicine program here at the Seattle Cancer Care Alliance, which I'll refer to as SCCA, we developed a vision for what we're trying to accomplish. So we think that our vision is for integrative medicine therapies to be integrated into all aspects of cancer care and will become standard of care as long as those integrative therapies are effective. We want to focus on improving quality of life and increasing resiliency from the time of diagnosis through treatment, survivorship, and end of life. Our emphasis is on evidence-based approaches, acupuncture, mind-body therapies, lifestyle behaviors, and counseling on the appropriate use of dietary supplements. And we're very highly interdisciplinary. And so we have 4 different aspects to our program, and I'm going to talk to you about that today: clinical care, research, education, and clinical practice guideline development. Next. So first, clinical care. Next. So integrative medicine SCCA. So we're a new service here. We launched in January of 2018. We have an interdisciplinary team of providers. We have an integrative nurse practitioner. I see patients as a naturopathic physician, and we have a large team of acupuncturists. We bill for all of our services. So some integrative medicine programs at different places across the world, some places have philanthropic funding that they use to support these programs. Here in Washington State, we're unique in the country in that in 1994, I believe, our insurance commissioner mandated that integrative therapies are covered by the majority of health insurance plans. So this excludes Medicare, and this also excludes some of the employer-based programs, but all of the private payers are required to cover acupuncture, massage therapy, chiropractic care, and naturopathic medicine. We share an electronic health record. We're just part of our system. We recently switched over to Epic, and we've survived that. And Epic is tremendous. It's wonderful. But we share a medical record with all of the providers here at SCCA. We are co-located within SCCA outpatient oncology clinics so that we are working right alongside all of the providers. We don't have our own building, though it would be lovely to have more space. We really like being integrated into the clinic so that we can be talking to all of the providers who are working with patients. And importantly, and certainly relevant to SWOG, is that we use this work as a research platform. Next. So within SCCA, integrative medicine sits within our interdisciplinary supportive care division. So we have a very large supportive care division that actually has just been restructuring recently. So within that, we have our nutrition program, physical therapy, spiritual health, social work, psychiatry and psychology, palliative care, and pain. And so we work, administratively, we work with these teams, but I think most importantly, clinically, we work with these teams, and on some of our research projects, we work with these teams as well. And so that's been, those have been some really fruitful and wonderful collaborations. Next. So this is some of our team. Well, this is all of the names. I don't have pictures for everybody yet because we just hired a couple people this month. So again, I see patients as a naturopathic physician. Susanna Myers is our nurse practitioner. And then we have a whole team of acupuncturists who are both working in our clinical work and then all of our research work. We just hired a nurse who's an integrative, a nurse with a specialized training and interest in integrative medicine. And then we also work very closely administratively with our service line manager in the clinic, who helps us with a lot of our strategic planning and some of our operational goals. So next slide. Now I'm just going to walk with you through to talk just a little bit about what these people do in the clinic and what our training is, just so that you can understand that a little bit more. So Susanna originally trained in massage therapy. She then went on to get her training in nursing and then eventually became a nurse practitioner. She actually served for 10 years here at SCCA as a GI oncology APP before she decided to switch over and start working with our integrative medicine team. So her clinical practice really focuses on the appropriate use of dietary supplements. Lots of patients come in asking questions about dietary supplements, and we are very conservative about those. She works really closely with patients on using mind-body medicine for symptom management. And then she is really, creating partnerships with patients as they're moving, through their cancer journey. Next. So this slide just talks a little bit about my work as a clinician and some of my training. So I was trained at I'm talking about this because a lot of people don't know what a naturopathic physician is, but here in Washington State, we function as independent physicians. I'm licensed, I attended a school called Bastyr University. It's a 4-year program. The first 2 years are very similar to conventional medical school. The last 2 years are very different in that we work with patients in an outpatient clinic and work a lot on wellness and well person exams and a lot of chronic disease management. And then there's some people go on and do residencies and fellowships after that. I also have some training in acupuncture. I have didactic training. I haven't done all of the clinical training. I'm a past president of the Society for Integrative Oncology. I'm a member of the Academic Consortium for Integrative Medicine Health, and I've been running an NIH-funded research portfolio for almost 20 years now. And so when I work with patients, I spend a lot of time on helping them evaluate what their goals are for care, and then what they want to do, what evidence do we have to support their goals and help them make some appropriate decisions. And I refer out widely to our team of supportive care clinicians here within SCCA. A lot of my research focuses on nutrition, physical activity, and weight management. And so I do spend a lot of time talking to patients about that. Next slide. So I'm going to just introduce 2 of our wonderful acupuncturists to you. This is Jonathan Simon. He worked as an acupuncturist at Memorial Sloan Kettering for many years, and I was very happy to recruit him to come move to Seattle to help build the acupuncture program here. He has his doctorate in acupuncture and Chinese medicine, and he had a lot of experience at Sloan Kettering and working on his acupuncture clinical trials there, and then he's brought that expertise to us here. His clinical focus is mitigating the side effects associated with chemotherapy, radiation, and surgery. focuses a lot on nausea, pain, hot flashes, neuropathy, xerostomia, and insomnia, and really is looking at improving quality of life for patients during all stages of cancer care and survivorship. Next. Susan Velleber, we recruited from when she was at the Cleveland Clinic as working as an acupuncturist, and she, before that, was working at the Mayo Clinic and also has a lot of experience building acupuncture programs and conducting acupuncture research. She's board certified in reproductive medicine and women's health, and so she brings that expertise to our program. And she has the same clinical focus as Jonathan. And Susan's been really instrumental in coordinating and managing all of our research acupuncturists who are working on our acupuncture trials these days. Next. So one of the things that we've done, I think a lot of people know that patients come in and have a lot of questions about dietary supplements. And so we've created a new collaboration between our integrative medicine department, nutrition, and pharmacy, where we've created clinical practice guidelines on the use of dietary supplements in SCCA general oncology patients. And we're in the process of writing that up. And so hopefully that will be available for everybody to see in a publication soon. Soon-ish, I would say. But I think importantly, what we're really trying to do here is develop standardized clinical pathways on how clinical teams can review dietary supplements and cancer treatment interactions, how to put that information in Epic, and then really so that information is shared across the clinical team. Because what we end up seeing a lot of times is that information was, discussed on a phone call or buried in an email. So Epic's actually really helping us make that more systematically available to the whole clinical team. Next. All right, so now research. So next slide. This slide just summarizes our active trials that we have open and some of the ones that we're doing data analysis on. And we're hoping that these are all local trials right now, but we're hoping that these are going to be, if fruitful, that we will bring them to SWOG as multi-center trials. So the first study is a study where we recruited breast cancer survivors who were post-treatment. And originally, this started before COVID, we were going to run in-person nutrition and physical activity classes for them, and to see whether or not, a low dose, a small number of these sessions would be effective at changing diet and physical activity in this patient population, or if they needed to come in more frequently. So we were testing 2 different dose levels of this intervention. And the main outcomes were looking at change in diet and physical activity. So then COVID hit, literally the weekend that we launched our first class. And so we paused and we converted the intervention to be delivered online in a virtual format. And so we just have finished data analysis and are analyzing that right now. But we're really excited about that. That actually pushed us to develop our methodologies more quickly than we thought we were going to, because now if we find that this is an effective way to educate patients and support them in diet and physical activity changes, perhaps this is something that we could bring to SWOG and open up here in this standardized way using Zoom technology. And hopefully other people's slides will be able to be shared. But then, so that's a diet and physical activity trial, but we actually have 3 acupuncture trials open right now, and we have one that's coming the way. And so we have one trial that's with our GI oncology patients receiving oxaliplatin-based chemotherapies. And we're checking to see whether or not acupuncture can help reduce CIPN and improve patient-reported outcomes. Stacy Cohen, who is a GI oncologist who's an active member of SWOG, is the PI of that trial. So that trial is actively accruing right now. We have another study that is focused on bladder cancer patients who are receiving BCG installations. And we want to see whether or not our acupuncture protocol can help patient outcomes there and help them adhere to their treatment. Can be a very uncomfortable treatment for patients to receive. And so that study, the PI is Sarah Sutka, who's also a member of SWOG and an active member. She's a GU oncology surgeon. And so we're really excited to get a surgeon involved in an acupuncture trial. We are a site in a multi-site trial that's funded by PCORI, and the primary site is Sloan Kettering. And this is a study using acupuncture in myeloma and lymphoma patients receiving auto transplants. And here we're just testing to see whether or not acupuncture can decrease the use of opioids and improve pain management in patients post-transplant. And so we're actively recruiting for that. And that's actually a large trial with 300 patients, but we're really excited to be working with BMT patients. And then this is hopefully something that we can also do some further multi-site studies in the future. And then we have a new study that we're just in startup phase right now. That's a pilot study with patients, sarcoma patients who are post-surgery, and we want to see whether or not our acupuncture protocol can help reduce pain in this patient population. So as you all know, research, we all need to be very patient with these, but we're excited to hopefully bring some of these to SWOG in the future. We have a very successful, we did conduct a very successful SWOG trial, in acupuncture trial within SWOG. The model that we use for that at Columbia, we conducted 2 pilot studies with an acupuncture protocol to see whether or not acupuncture could reduce aromatase inhibitor-induced joint pain in breast cancer survivors. And we showed that the protocol was effective. And so then we took that to SWOG and we conducted a large-scale trial within SWOG. This is S1200. That was effective, and that paper actually has gotten a lot of press and has, I think, actually been really instrumental in helping promote the use of acupuncture in cancer centers across the country. So thank you to all of you who worked on that trial. Okay, next slide. So another project that we're working on here, and I guess you're all at your computers now, so go open up an additional browser on your website and go to cookforyourlife.org. This is a website that we run here out of Fred Hutch now, started in New York City at a nonprofit called Cook for Your Life, and I did research with them for quite a few years. The founder of that is a cancer survivor, Ann Ogden Gaffney, and she was doing community-based nutrition classes for cancer patients in and around New York City. And when I met her, I said, well, this is a really interesting program that you're doing, but how do you know if it works? And if it does work, how do we get into the hands of more people? So fast forward, Ann and I applied for a couple of grants to NCI. We were funded to take her program that she was doing specifically in Latina breast cancer survivors. And we then created a formal curriculum based on her program, and we tested that in a couple of different settings. And then decided that she was retiring. And so here we absorbed her website at Fred Hutch. And so we have now taken this and we're adding a lot of information to patients. If you can do the next slide, please. There's a lot of nutrition information for patients and caregivers and clinicians on cancer prevention, the use of nutrition during treatment and during cancer survivorship. So we're doing some studies with this right now. This is a freely available resource to you and your patient populations that you're working with. So feel free to distribute this information. But we are hoping to bring some trials to SWOG using this research platform going forward. Next slide. So I just want to talk briefly about a couple of training programs that we offer in our program. We are part of the supportive care rotation for our NCI-funded medical oncology fellows. Those fellows shadow our integrative medicine clinicians. They present cases during case management meetings, and they conduct experiential learning. And then we also have an integrative medicine rotation for our APP oncology fellows. So we're really excited to be part of the training program. And so we talked to them both about the clinical work that we're doing, but also the research. And we're hoping to recruit more fellows to do research in this area. Next slide. Next. So I'm just going to talk very, very briefly about some of the work we do around clinical practice guideline development, because all of the work that we're doing here in SWOG in our integrative medicine trials, eventually our goal is to get that into clinical practice guidelines to help affect clinical practice decisions on the use of integrative therapy. So in clinical practice guidelines, we define a clinical problem. In this case, should patients use integrative therapies during oncology care? We conduct a systematic review of the available evidence to date. We then develop clinical practice guidelines and we push that out into the communities that need it. So next slide. So there are 3 main bodies that we've been working with on clinical practice guidelines. So ASCO, NCCN, and then the Society for Integrative Oncology. So I'm just going to give you a brief update on that. Next. So I'm the co-chair of the SIO Clinical Practice Guidelines Committee, and in 2017, we published a set of clinical practice guidelines in the ACS journal, CA, a cancer journal for clinicians, and this is on evidence-based use of integrative therapies during and after breast cancer treatment. A couple of things to note here: 2 SWOG trials were featured heavily in these grants. One, S0715, was tested whether or not acetyl L-carnitine prevented neuropathy in breast cancer patients receiving taxane therapy. And unfortunately, we found that it made neuropathy worse, but that was very important information to have. There was evidence to suggest that neuropathy, acetyl L-carnitine would be helpful to prevent or treat neuropathy, but that isn't what we showed in our trial. And then S1200 was the acupuncture trial for AI-induced arthralgias. And we got some good, we made it to Time and Consumer Reports, which let us know that people were going to actually read some of our study results. We're excited about that. Next. Then ASCO picked up our guidelines and endorsed those, which we're very excited about. And so our own Gary Lyman helped steer that effort. So Gary's very involved in SWOG. So next slide. And we have 3, we've now developed a new collaboration between ASCO and SIO to work on 3 guideline projects going forward. And so hopefully in the coming year, you'll see guidelines out on the use of an integrative approach to cancer-related pain management, update on the fatigue guidelines, and to have more information about integrative therapies there, and then integrative oncology care of anxiety and depressive symptoms in adults with cancer. So next. And oh, you can just scroll through the bottom of these. So this is just my last slide. So integrative oncology is a growing field. We're very interdisciplinary. We do have a growing body of evidence suggesting that some of these integrative therapies should be rolled out routinely in clinical practice. And a lot of that is, partly due to the work that's being done in SWOG. We do have need for future clinical practice guidelines. We're finding out that's a really good way to disseminate information out into clinical settings on how this work can influence better patient care and better patient outcomes. We still need to conduct many observational studies and clinical trials. And importantly, clinical programs and cooperative groups can provide an excellent infrastructure for conducting the research in this area. So I just want to thank all of you for the work that you do to help allow us to do this kind of research. So I think I've got some, that's my last slide, and I have time for questions. Thank you all.
Thank you so much, Dr. Greenlee. I cannot tell you how much your work has benefited our patients. As an oncology nurse for 22 years, I can count on one hand the number of days that have gone by where I didn't get a question from a patient about integrative approaches to their own self-care. So we really are grateful for helping us delineate what's true and not true in that arena. And so with that, I want to make sure to see if anyone had any questions. We have a moment or two to answer some questions for Dr. Greenlee while she is still here.
I have a couple questions, but I think these are directed towards Amanda.
Go ahead.
Great. Well, thank you all. I just want to thank you all for, I can say one of the things about the SWOG trial, about S1200, is that we were able to train 60 acupuncturists across the SWOG networks to be able to work on this trial. And a lot of that had to do with all of the research operations and all of the folks who are sort of behind the scenes making this work. And so I just want to thank all of you for helping us develop that infrastructure. And I'd say if people have information going forward, please feel free to reach out. So this is, somebody just asked a question, Julie asked a question, where does one start if they want to initiate an integrative program in our clinic? That is such a good question. I think it actually starts at the very top. I think what we learned is that it really requires buy-in from the institution to want to start a program. They need to be willing to give institutional resources to hire people, to give people space, and to hire enough people so that it's actually a robust program. And so I think if there's interest there, I think it's important to go talk to center leadership and see if there's interest there. Some people do it the opposite way. They sort of start a rogue program, which can also be very useful to just get something started. The problem with that is a lot of those programs, if it's just one or two staff people doing this, that can be problematic in terms of growing the program eventually if there isn't institutional buy-in. I would say a lot of times integrative medicine therapies are talked about by the staff sort of under the radar. And I think it's really important for it to be above the radar. And so I think this is one of the reasons why we're trying to get information into Epic and to make it as transparent as possible about what patients are doing and also what works and what doesn't work. Let's see, Lisa, it looks like you might have a question.
I wanted to assure everyone who's on the attending today, we in the background here are gathering all the questions. And so if we are unable for whatever reason, or if you submit a question late, we'll be gathering all those questions and we're going to be publishing the answers to those in both the newsletter, and we'll put them up on the workbench under our ORP site as well too. And again, if you have any questions, send them orp@swog.org. We will filter them to the appropriate folks. Dr. Greene, we are incredibly grateful for your participation today. I think I want to move to Seattle.
Welcome. We're trying to grow our program, but we struggle with institutions have a lot of competing priorities to start integrative medicine programs, and so I can just say, our palliative medicine team is underfunded. Our psych team is underfunded. And, when we're looking at across what patients needs, it's very important to have robust palliative medicine and psych programs in addition to integrative medicine programs. And so that's one of the reasons why we're all collaborating together and saying, okay, well, this is what our program can really do and be the most efficient at providing effective information. And so that's also why the SWOG trials are so important, because when patients come to us and say, what should I do? Here's this list of 30 things I'm interested in. We can more specifically hone in on what is useful for them and to meet their goals. So I just want to thank you all for the opportunity and enjoy the rest of the SWOG meeting.
Thank you so much, Dr. Greenlee. And with that, I'm going to turn it over to Deb Bergevin, who will take over for open forum.
Christine, we did have a couple of questions. Do we want to try to get those in, or it looks like those may have been one intended for Amanda?
Yes, let's try with that since we have a little bit of time. Thanks.
Okay, so there's a question. Has there been discussion about implementing some of the DTL features to RUMs, in particular site and role assignment, for example, assigning registrar to a staff at multiple sites in one click versus assigning at each site? I'm not sure if Amanda's on.
I am here. There has been some discussion, but let me take that question back and answer it in more detail. So if you will just send me that question, then I can take it back internally.
Okay, and then there's one other. It said, I've experienced the integrated SAE program telling me I need to submit an SAE, for instance, to the protocol for a protocol that has an exemption, such as a grade 4 ANC in a leukemia trial. I guess they're wondering if that is going to be more intuitive.
Yeah, so, but there is some concern that the programmed rules and CTEP errors for what is reportable and what is not reportable may not be, perfect in every way. And when you have, so, I will say that, the spear and caper that is often in the protocol should be taken into account in the programmed rules. However, they can only apply the rules to one agent, one IND agent, and when you're using when you have a cocktail or multiple medications that are being given, and you're trying to apply an adverse event to a specific drug within that cocktail, the rules kind of start to break down. So, and if you have multiple arms, the rules can start to break down. So, I would just say, here's what we tell everybody, and this should work. The investigator has ultimate responsibility for what is reportable and what is not reportable. The recommendation is exactly that. It is nothing more than a recommendation. So if the investigator feels that something is reportable when it says it's not, or something is not reportable when it says it is, the investigator is the ultimate arbitrator, right? The investigator can override any recommendation as they see fit per the protocol. So.
Okay, I think that answers those. Those are the only two.
Thank you. Thank you, Amanda.
Mhm.
Next slide, please. Oops, back one. Well, hello and welcome to Open Forum. I'm Deb Bergevin, the Open Forum Chair for this SWOG's fall meeting. Just a reminder that this session is being recorded and the accompanying slide deck will be available on the SWOG website. Next slide, please. A quick review of the agenda shows us starting with a discussion on opportunities for improvement with tips for success from an exemplary site panel. After the site panel discussion, we'll have a back to basics interactive session, and then we'll wrap up with some audience questions to our presenters and panelists. A couple of housekeeping items. Please use the Q&A option to submit your questions instead of the chat line. The Q&A option will be monitored by Education Committee members, who I'd like to thank for their efforts in keeping us straight there. We'd also ask, if possible, for you to include the name of the person you are directing your question to, so that it can best be filtered and addressed. And finally, we'll do our best to verbally answer your questions at the end, but if we don't have time to get to all of them, we've asked our panelists and presenters to provide written answers, which will be posted to the SWOG website. Next slide, please. We have some of the best from the SDMC and the Operations Office. Hannah, Louise, and Diane, data coordinators, and Laura, a nurse auditor, are here to showcase some common errors made by sites. After their comments, I'll return to introduce the site panelists. Hannah, I'll turn the next slide over to you.
Thanks, Deb. Next slide, please. This is just kind of another introductory slide. Something I'd like to point out here is the SWOG SDMC phone number down at the bottom. If you cannot get a hold of us by email, or if you have an urgent question, this is the best way to reach any of your data coordinators. I am Hannah. I work on the melanoma and the myeloma committees. I'm a data coordinator. I've been with SWOG for about 2 years now. These areas of improvement that we're going to be discussing were compiled from input from the entire data management team at SWOG, and we are really happy to be able to present this to you. Next slide, please. I am going to be covering some of the data entry improvement areas that we have discussed. The first one that we wanted to discuss with you is that we experience a very high number of open and SWOG specimen tracking errors that we are asked to amend. We just ask that you be extra careful and please double check and confirm all of the details prior to submitting this information. This is the first information that's entered for your patient, so it's very crucial that this gets entered in correctly. The second thing that we would like to discuss is units for lab values and other items. The units in the EDC may not match your lab's reports. It's very important that all values are entered in the EDC are reported in the correct units. This makes sure that we can compare all of the labs accurately and efficiently. One of the most common is ANC and platelets. Sometimes they are very commonly reported in just cells per unit. SWOG in most studies requires them to be entered in microliters. So you have to multiply that value by 1,000. A lot of times you're going to get a query if you just enter it in how your lab reports it. So just please pay extra attention to the units that we provide to you in the EDC. This also applies to treatment doses. Sometimes you have to enter them in milligrams. Sometimes they need to be in milligrams squared. It just depends. Pay attention to your protocol. That'll all be in section 7. Let's see. Additionally, doses delivered, planned, and the total dose on the cycles forms in the EDC. If a patient is planned to receive a specific dose, which is going to be found in section 7, that's going to be your planned dose. What is actually given to the patient is the dose delivered at the cycle end, and your total dose is going to be that cumulative amount. You want to add it all up together. Some studies only require one treatment for the entire cycle. Others have a patient dosing daily, so you'll need to add up that total dose given, and that's what we're looking for there. Dates are another common issue that we run into. Reporting periods for treatment and AE forms should match. We cannot have an AE that is outside of the reporting period for the treatment. It doesn't work that way. If your study uses AE dates for your registration trials, you want to make sure that that AE date falls within the AE reporting period. Another tip, unless you're starting a form to report an SAE, treatment forms should always be entered at the end of the cycle. This is in the instructions on the EDC form, but it's really important that the cycle is entered after everything has happened so that you can completely enter that cycle. One thing that we notice a lot of is the date of last treatment is not filled out. That is very important. We need to know when the patient last received treatment for that cycle. Again, some patients only receive one treatment, so that date might be the same as the treatment start date. Other studies require a patient to dose for the full 28 days. If they only dose for 14 and that is the last date of treatment, that is the date that you must enter. We always want you to enter in the accurate information of what happened, not what it's just supposed to be. Back to reporting period dates. The start date is almost always the first date of treatment for the cycle. Some studies are a little bit different, but generally that's a good rule of thumb. The reporting period end date should be day 1 of the next cycle to ensure that we're able to see the entire reporting for that time. Some studies may be slightly different, and if you have any questions, please reach out to your data manager by using the distribution list for your study. For example, mine would be melanoma question@crab.org or myeloma question@crab.org, or you can always call that phone number that was on the introductory slide. And that is all for me. I will pass it on to Louise. Thank you.
Thanks, Hannah. Next slide, please. Thanks. So my name's Louise. I work on the lung and leukemia committees, and I'm going to be talking about some improvement areas regarding the upload of source documents. So in RAVE, we ask for only limited source documents to be uploaded for every patient. And the required source documents are always listed in protocol section 14 in the data submission schedule. We recommend that you check here first before completing the source documentation forms in RAVE. That way, you will be sure to include the documents that we do want to see, and it will save you the work of redacting and uploading extraneous source documents that we do not need to be uploaded in RAVE. So checking section 14 is always helpful before you begin on the source documentation forms. Another thing to do to reduce queries and issues is to make sure that before you upload any documents that all PHI and patient's name has been fully redacted from the source document. Common errors in this area include missing a name that's in the body of the document, not just in the header or the footer. So for instance, if like the physician has in their dictated part of the report, you know, Mr. Blank, just make sure you look for that. Those can be missed pretty easily. And then another error is just incomplete redaction. And this often happens when you're using a black marker and then using a scanner. Some of the scanners these days are just so good that they read through the black marker. So before you upload a document, make sure you double check and look at the PDF version and make sure that you can't read the patient's name through whatever redaction tool you're using. So that will help reduce queries because we will query if we notice that we can read the patient's name. In addition to redactions, source documents that are going to be uploaded in RAVE must be labeled with, at minimum, the patient ID number on at least one page. That's the 6-digit SWOG patient ID number. we also do recommend that you include the study number, for instance, S1701 or whichever study it is, and the patient initials. And this is commonly missed and can lead to extra work on both of our sides. So if you just think before you upload any source documents to double check for redaction and labeling, it will save a lot of work in the end. And finally, for registration intent trials, so these are these FDA registration intent trials that have central monitoring. The central monitoring is usually done on the first 2 patients enrolled at a given site, and it requires uploading full source documents to the CTSU source document portal, or the SDP. And the trick here is just that is a different system and is reviewed by different people than the RAVE source documentation form. And so just uploading something to the SDP does not meet the requirement for the RAVE upload, and vice versa. So just make sure that you do both if it's requested for those first 2 patients, or whichever patients are selected for central monitoring. All right, that was what I had for source documents, and now I will turn it over to Diane for the next slide.
Next slide, please. So, thank you, Louise, for the source documentation reminders. Today, I will discuss the following 3 issues with protocol implementation that occur and provide SWOG resources that will help you with improving and determining data submission for ineligible patients, the disease progression, and patient refusal. First, for the patients deemed ineligible. For SWOG studies, patients must meet all eligibility criteria, which can be found in Section 5 of the protocols. Unfortunately, sometimes on a later review, it is found that a patient was ineligible after being registered to the study. So now what are you going to do? Well, I'd like to remind you that the patient will still need to continue to be treated and followed per the instructions found in the intervention section of each SWOG protocol. This is usually Section 7 of our protocols. On some studies, this can mean that the patient will need to be taken off study intervention or off treatment protocol. So this is very important to check in your protocol. Make sure you check that if you have a patient that is deemed ineligible. Data should continue to be submitted as best as you can for ineligible patients. This is especially true of the baseline forms. We still expect the baseline forms to be submitted. If you have trouble with that, please contact your data coordinator. And some of the useful guidance from that is the data submission section of the protocol, which is usually Section 14 of protocols. Very helpful on when you need to submit those forms. Also, the best practices document and the ORP manual has a lot of wonderful information in it that can be helpful and guide you. I'd also like to mention form instructions on the study master forms, and we also put some help text in RAVE, and that is designated by that little question mark you'll see by certain questions on that. We do that to try to help you answer those questions correctly. I would also like to say, if you still have questions after reviewing all these resources, please contact your SWOG Data Management Center using the email address or phone number listed on the CTSU address and contact information page that you can find in each of our protocols. And what this will do is get you in contact with the SWOG Data Coordinator. Again, that's the same thing that Hannah was talking about. Each of the disease sites, we have our own DL list, and if you contact them, a data coordinator can help you. It is also helpful if you can add a note in the comments section on the on-study form acknowledging which eligibility criteria the patient does not meet and the reason if a question cannot be answered on the form. Next, I will discuss the patient progression. So it is very important that disease progression is determined and documented correctly, since for many studies, it is our primary study endpoint and may require that all patients be taken off treatment or off protocol. Some of the resources to improve determining patient progression and document it correctly can be found in the study protocol in section 10, which is the criteria for evaluation of endpoint analysis. Also, again, the ORP manual, section 11, it has some guidance on completing response assessments if that's appropriate to your protocol. That might not be appropriate to all protocols, so check your protocol to make sure. And then reviewing the master forms instructions also and the help test can be very beneficial again. Using these resources, this should help you determine, has progression been determined by the study protocol? How should progression be documented correctly in RAVE? And does the off treatment or off protocol notice forms need to be submitted? For patient refusal documentation, the reminders I have here to improve documenting refusals are to keep in mind that SWOG policy 30, item 9 indicates that withdrawing consent to participate in a study does not necessarily mean the patient also withdraws consent to be followed. You must determine with the patient whether they no longer wish to be treated per protocol, they no longer wish to be followed per protocol, or both. Follow the intervention and data submission sections of the study protocol for when to submit the off-protocol form and off-protocol notice. These sections can be found in section 7 and 14 of SWOG protocols. Also remember to document in the notes or comments section of the follow-up form, off-protocol section of the follow-up form, off-protocol form, and if appropriate, the off-protocol notice, which category of refusal has the patient requested. I'd also like to recommend reviewing the ORP manual chapter 10. There are some great examples in like page 2, page 5, and page 6 that I think would be very beneficial. Next slide, please. Finally, there are multiple links to the SWOG policies, best practices document, and ORP manual on the SWOG.org website. And this slide just shows some of my favorites to help you navigate to that. And there were some others in the Oishi. So just wanted to let you know how to get there. And I'd like to thank you. And now I'd like to introduce Laura.
Okay. Well, thanks, y'all. Next slide, please. So my name is Laura Gonzalez, and I am a quality assurance nurse auditor here at the operations office. And I'd like to thank y'all for this opportunity to talk about some areas for improvement from an auditor's perspective. So I've been a nurse auditor with SWOG for about 5 years now. And next slide, please. So from a regulatory perspective, one of the issues that we see is providing the documentation of local implementation dates of revisions for the CIRB studies. And that's most of the ones that we do when we're doing the registration studies. And so the recommendations that we make when we see best practice would be tracking log spreadsheets, copies of the email blasts to the site staff, or implementation dates on the informed consent documents. So however y'all do it, these are some of the ways that we've seen that work very well. So what we just need to see is that you're meeting that 30-day guideline from approval from CIRB to implementation at your site. So however you can show us, we're happy to see. And these are some of the best ways that we've seen when we go to sites to audit, or when we're doing remote audits, as we've been doing for the last year and a half. That's what we like to see. So next slide, please. Data submission is another area that we've seen, delinquent data submissions. Some of that, as we've been working through COVID, we know that lots of sites have had furloughs and they're working with much reduced staffing. So some of that has been related to has caused delinquent data submission. But we would want you to always refer to section 14 in the protocol for your data submission guidelines. The other thing is that if there are issues with data submission because of COVID, please use the COVID-19 diagnosis and protocol deviation forms in RAVE, because if that's an issue that you're submitting data late because of staffing issues or whatever, that a lot of times can subvert a deficiency because of COVID. I mean, if you've run into these issues because of COVID, put it on your deviations form in RAVE, and then when we come to audit, we can look at it and we can say, oh, well, they've run into an issue because of staffing, because of COVID, because of whatever, and then you can see that. But the other thing too is that any protocol deviation needs to be documented on that COVID-19 protocol deviation form. So all data submission needs to go with that. Oh, y'all are getting audio problems? Okay. Is it better now if I sit closer to my computer? Next slide, please. So, okay, thank you. So the other thing is that all of the data that you submit in RAVE must have a source for the auditors to verify. So think about that as you're preparing for an audit. If you have put something in to RAVE, make sure that if you're putting together a shadow chart or you're uploading into the source document portal, that you have a source for us to look at. And the other issue that we've seen is that if you're using a CRF as a source document, that the CRF must be signed and dated, okay? Next slide, please. So then this is just a thing to remember, ALCOA plus C to achieve data quality. If it's not documented, it didn't happen. So ALCOA plus C, attributable, legible, contemporaneous, original, accurate, and complete. I'm sure this is something that everybody's seen and has heard of, but just a reminder. Next slide, please. And then specimen submissions, refer to section 15 for specimen submission guidelines. Make sure that you enter all your specimen submissions in specimen tracking. And if you can't submit it, also enter that as an unsubmitted specimen. Again, that can save you from a deficiency. If there's a reason why the specimen cannot be submitted, enter that into specimen tracking, and then we'll see that there was a reason. There wasn't adequate tissue, the patient was unable to submit the blood for whatever reason, put that in specimen tracking as well. Next slide, please. And then for audits, make sure that if you're going to provide EMR access, that if you can provide it prior to the audit, then that way we can make sure we log in. That saves time on the day of the audit. If you're uploading documents into the SDP, into Florence, Dropbox, etc., make sure that the naming conventions are consistent. It makes it easier for everybody that we can find things. Following the instructions, if you're uploading documents into the site document portal, that way, otherwise we're not able to see them. We ask you to upload them into audit packages. That way we can get to them, because there's a way that things flow for us into CTSU and the site document portal. And so it's really important that you follow those instructions. And we usually send it's site instructions for SDP. And so we just ask that you use that. If you have any questions, you can always ask us. We're happy to help. Next slide, please. And thank you for your time.
Thank you, Laura, and all the presenters for your guidance and helpful resources. We'll now hear from site panelists identified by SDMC and the SWOG Operations Office as sites that have been successful in mitigating some of these areas of improvement that we've just heard about. They represent a diverse panel from large consortiums to smaller affiliate sites and will provide us with some tips that they have found to be successful. We'll hear from Gayatri Nachagari from the University of Utah Medical Center, Arcadia Cruz and Edward L. Curry from UC San Diego Moores Cancer Center, Sue Jonas from the Cancer Research Consortium of West Michigan, Carol Boves from Winchester Hospital, an affiliate of Leahy Hospital and Medical Center. A colleague of Tony Hyatt, Danielle Leary from Sacred Heart Hospital will fill in. Sacred Heart Hospital is an affiliate of University of Arkansas for Medical Sciences. Karen Miller and Lorraine Post from Louisiana State University Health Sciences Center, an affiliate of Gulf South Minority Underserved NCORE. And then we'll finish this discussion with audit tips from Maggie Sell from the Fred Hutchinson Cancer Center. Gayatri, we'll start the next slide with you.
Thanks, Deb and the ORP committee for providing me the opportunity to present at this forum. Hello, everyone. Hope everybody is doing well. In clinical trials arena, as you know, we have several guidelines, policies, trainings, audits, etc., right? These processes help us to develop the best practices for our day-to-day activities at individual or at the site level. So today I would like to share one of the practices we have implemented for our NCI sponsored trial. We call it as NCI sponsored trial focus group meetings. Before that, let me introduce myself and my site. I'm Gayatri Nachagari. I manage the NCI program at Huntsman Cancer Institute, University of Utah, and our affiliate sites too. Our cancer center is part of the UG1 grant or the LAPS grant. We are members of SWOG, Alliance, NRG, and apart from that, we are awarded with a UM1 grant to run the ETCTN trial. So next slide, please. Focus group. It's a forum for our site coordinating team members who are working on the NCI sponsored trial. We meet on a monthly basis. And why? It is to, this is a platform to develop a continuing education training program and to improve the quality of our work. And how we do it is via this meeting, we provide a platform where we discuss all aspects of NCI trials. Next slide, please. So to explain better, I provided a format and an example of the topics we discussed from the recent one. So the first section, what we try to do is we try to put a reminder or a training for our team members. And these are mostly based on the current requirements of the team or to discuss audits and the corrective and preventive actions we have taken. And the second part is the peer-to-peer review, which I'll get back. But for example, one of for the first part for our last meeting, what we discussed is data expectation, obviously, which is one of the most common things we generally discuss every time. And then the next one is the recent, the APCs signing off on the prescriptions. We discussed with all our team members so that they are aware of it. If they have any questions, we have discussed about those and some tips like rave pop-ups, help text and all those things. And then we discussed about the COVID-19 deviation reporting and a reminder, about what to do and what not. And the second part is the peer-to-peer review of EDC process. This section is mostly learning from each other. We learn a lot from our mistakes, sometimes from our peers, a lot of things. So every presenter gets 5 minutes. Next slide, please. So what we do, one patient chart is picked from each disease group, and the data coordinating teams are notified of selected patient charts and topics few days before the meeting. For example, last time we picked date of confirmation of histology and lesion evaluations. So, these are very simple topics, but there are discrepancies we have seen. For example, the simplest thing is date of confirmation of histology. What happens is there are sometimes a reread of the pathology reports, and the date which is entered is the reread, not the exact day when the biopsy or the histology was done. So those are the small details. Like we pick every meeting, we pick one topic. Then during the day of the audit, the data coordinator shared the screen to show the EDC as well as the source document. And overall, with this, what we do is we discuss about the data entries, if they have any difficulties, then we check with the protocol requirements. Then we check on the NCI guidelines, or if there are any guidelines for that particular topic, or any best practices, or any other things which are available for that particular. If there are any questions, we suggest the teams to reach out to the study team, and then we do check the delinquencies during that peer-to-peer review and discuss the source, discuss resources also. So this is what we do in peer-to-peer review. Next slide, please. So every focus group meeting, we put a reminder for reminders and resources for this program. Next slide, please. Some of the resources are here, like NCI and institutions. All institutions have their own requirements. So just we jot down all the resources here, or what do you call all the requirements here. And sometimes we remind smaller topics, like, for example, NCI-sponsored trials, no exceptions to eligibility criteria is allowed, right? We have to fulfill all the eligibility criteria. It's just a reminding the teams about these are all the things which our institution have some policies or NCI's policies. Next slide, please. And we also share every time all the resources, like for NCT and NCORP resources, who to contact, and more details about how to contact. And this is just a resources. And also for next slide, please, we provide an NCE, DCT, and guides and resources and all those things. So with that, next slide, please. And with that said, we believe in teamwork, and I think we achieve success with teamwork. So thanks a lot for listening to me. And if you have any questions, please feel free to direct it to me or the panelist. Thank you.
Next slide, please. I'm not exactly sure if I see Dr. Cruz or Edward on. Are they here yet? Oh, I see
Hello,
Edward.
can you hear me?
Thank you. Yes, thank you.
Yeah. I need to apologize. I think we've got a mix-up in the times, and Dr. Cruz is not on right now. I'll do the presentation. We are from UCSD Moore's Cancer Center. We are fairly large group. We have 11 disease teams. The NCI clinical trials are controlled by the quality assurance teams that we are a team of 4 people. And we do all kinds of, Dr. Cruz is our team leader. And we do periodic audits, internal audits on all NCI cooperative group studies. We do data delinquency audits. We do even patient audits internally. Next slide, please. One of our, we created our own SOP data management that we provided to all our team. Every single new coordinator that we hire comes into us, and we do a 2 to 3 hour NCI group presentation, what is expected of them, how to run things, if they have any questions. Next section, next slide, please. One of our really big issues historically had been data management. We used to have a huge number of delinquent data, a lot of unanswered queries for many reasons. And we created, our team created team reports that we actually send, it says here on a monthly basis, it's actually bi-monthly basis now, on the 16th and on the 1st of every month. Each of our team receives a report from QA, which combines all their delinquencies, all their queries on all cooperative groups, with timelines of, you know, how long they are due, how long they are overdue, when they are due, and all of that. We have an expectation that data delinquency be resolved in less than 30 days, and we actually also do a compliance performance internally, so they need to at least be at 80% improvement. The delinquent data that are not completely resolved but in a report needs to be resolved by the following report within 60 days. We do this tracking on monthly basis, and in order to really get the compliance of everybody, CRCs, project managers, PIs, and team leaders are all copied on these reports. And as an added deterrent, if they do not achieve that 80% delinquency, our administration withholds 100% of the payment that we grant our teams for running those NCI clinical trials. I think we have gone down considerably right now. We have almost 80 to 90% compliance with our data delinquency as we go along. Next slide. I think that would be the end of it. As I said, we issue a team performance metrics. Dr. Cruz identifies the team that qualify for the monthly disbursement and payment. And if they don't get that 80%, they actually do not get paid. And basically at our site, it's a high incentive to get both project managers and PIs really involved in this. When these reports come out, right now, you get a lot, we do get a lot of feedback, excuses, explanations. You know, it opens the door of communication, and we do try to act as a conduit between our teams and the NCI cooperative groups. Next slide. And that's it for us.
Thank you, Edward. Suzanne, or Sue, you're on.
Hi, thanks very much for asking me to speak today. When I first was asked, I spent a little bit of time trying to decide what would be most helpful. I've been doing this job for quite some time, and as we all know, things change frequently. So I've become famous for a particular phrase in our department and decided to talk to you guys about that. I am a research nurse at the Cancer Research Consortium for West Michigan for a lot of years. There are facts and rules that we all need to know and follow. I believe that we all want to do the right thing. However, we live in the real world with all its bumps and detours. We make mistakes. There is comfort in the idea that there's a research jail waiting for those like me who've had run-ins with research facts and rules. I have, however, learned a couple things over the years that I'd like to share. What I wanted to talk about today is more about general wisdom than hard facts, so I hope you find it helpful. Go ahead and hit the next slide. The big question that we deal with is, how do you decide what you're going to do when you don't know what to do? One of my colleagues found this great slide for me from the show Family Feud. Most of you know the show is about guessing the most popular answers to a given question and getting points for picking the answers that matches what most people think. It is very tempting to use this method when we're stumped. I have been part of what seems like hours-long debates on how the data should be reported or on what the research base is really asking for. There's no winning in these kinds of debates in the office. There's no point in having the top answer. Survey says doesn't matter. What the research base means, regardless of what we think they said, is what really matters. I have a scenario to share that in real life could turn into one of these types of discussions. For instance, we're reviewing eligibility criteria for a patient. In this example, for a colorectal cancer that seems to meet criteria for S1613. When I come across the following eligibility criteria, 5.2.E. Patients must have adequate hematologic function as evidenced by all the following within 14 days prior to step 2 randomization. ANC greater than or equal to 1500, platelets greater than or equal to 75,000, and hemoglobin greater than or equal to 9. Well, his hemoglobin is over 9 because yesterday he had a transfusion. Does the fact that he had to be transfused to meet criteria mean that he does or doesn't meet criteria? This can spark a debate in the office that could go on and on as everyone weighs in on how they've managed this question in other trials. The problem is that the other trials being referred to were run by ECOG Akron or NRG or Alliance, and the disease sites for the trial being referred to could have been a completely differing primary. How those trials approach the question really doesn't help us in this trial. Not only that, but as the debate goes on, the potential for ear damage becomes critical as everyone raises their voice because the loudest is the most right? Then, not having believed what everyone says, completely disregarding the fact that you asked them what they thought you ought to do, you go down the road of, well, this makes sense to me. That's what I'm going to report. And if it's wrong, they can query me. When the query comes, because what makes sense to me isn't what the research base is really getting at, you will still have to figure out what they really wanted. But now it's been a while and you have to review the chart again and try to remember the scenario and what you already worked through, which will get you back to the question of what the right answer is. Although you know now at least one thing that isn't the right answer, the one that triggered the query you now have added to your task list for today. My advice post more of these discussions than I'm willing to admit to is that there's a way you can save a ton of time, aggravation, and possible queries from the research base. When you ask your colleagues if they have an answer to this question and no one has experience on this one, don't let it turn into a survey says to see what everyone thinks. There are people out there who know the answer. They have the answer that will get them the data they need to answer the question the protocol is asking. Has already been referred to by a couple of people. SWOG has a couple of really good tools that are available. My favorite is an email address list that's disease site specific for SWOG trials. You can find it on the CRA workbench. It's in the left margin and is the last item under the heading of resources. Just click on the words contact us and it will bring up your choices. When I have a question about how to manage some data for a lymphoma trial, I have the option to send my question to lymphomaquestion@crab.org. I'll put the protocol number in the subject line and send off my question. There's no need to see if you have the contact information for the last data manager you are aware of working on this study, hoping that hasn't changed. SWOG uses this method to get your question to the right person, and I have to say it really does work. I would like to send a shout out to Kat, who always answers me and never makes me feel dumb. Another resource I like is the memorandum titled Best Practices for SWOG Studies. The version dated 6/1/19 is the most current. And if it's not listed in the protocol, you generally can rely on what's listed in this memorandum. I followed my own advice and then not saved the answer, which means the next time I enroll a patient in that study, I end up going through the process of asking the same question again. Aggravation saving practice tip number 2 is to save your answer in a file so you can easily find it when you need it again. Another plus to saving your answer is that when auditors are looking at your chart and ask you why in the world you submitted data the way you did, it doesn't always make sense to them either. You can show them the email and they very happily move on. The other point I wanted to make was about procrastination. When you are buried already, procrastination is your enemy. I have seen it take down more than one research nurse. They normally bounce back eventually, but it's not pretty. Problems with procrastination number 1. Just yesterday, the data was due next week. Then you turn around and discover that the next week date you had in mind has turned into a date that passed 2 weeks ago. What the heck? Problem number 2 with procrastination is that people forget things. It's not just those of us who've entered the world that is menopause. It also hits our chemo brain patients. I have found it impossible to report symptoms that sound like, well, a few days ago, I felt kind of funny, just didn't feel right. I'm not really sure how to describe it, but I feel better now. They don't mean to be vague. They just feel better with the misery in the past and would rather not relive it. At least most of my patients feel that way, and so do we. The takeaway is just do the data, get it done, and put it behind you. I did briefly consider talking about lab value conversions, but the only real message that I can give you is that you can Google conversion calculators online, which might help you get the right numbers. I would ask SWOG to consider adding a tool to the CRA workbench that would allow you to convert the lab values most often built into the data forms. No pressure to the powers that be who set up the CRA workbench, but if anyone else would find that useful, I'd be happy to pass along that message. Thanks for listening. We're doing an important thing, so hold your head high. Next slide. Frantically figuring out how to mute myself.
Thank you, Sue. That was fabulous. Carol, on to you, please. Carol, I'm not sure if you can hear us. We can't hear you. You don't look to be muted, but we can't hear you. Hey, Chad, just because time is of the essence, do you think we can move on to Danielle at the next slide and then pop back to Carol when she has taken care of the audio problems?
Sure, yeah, of course.
Danielle, thank you. You're up if you don't mind.
Can you see me okay? Okay, great. So my name is Danielle Leary. I am a research nurse here with Ascension Sacred Heart Cancer Center in Pensacola, Florida. We are a SWOG member through our parent organization, the University of Arkansas, and we are a community site with 13 investigators, and our cancer research department is 3 full-time staff and 1 part-time research nurse. We are also responsible for maintaining regulatory documents, data entry, protocol management, and coordination of care for the study patients. And so we wanted to talk about how we work together as a team to be able to do all of those. So first, we want to start by saying thank you to Casey Simpson. She was the Assistant Director of Clinical Research Operations at the University of Arkansas. And she, for a long time, has been sending us monthly emails, sending us encouragement and telling us we're doing a great job and keeping up with any of the data that is both due and if we have any delinquencies. So having that check-in once a month has been very helpful for us. Now for our site, our teamwork and communication is the big success that we have. We share calendars. We have a combined spreadsheet that we do to take care of all of our patients that we have on study and anyone that we're screening. We also make sure that we use color coding for all the activities that are doing. So we keep track of it with data that's due, anything, visits that are planned, any kind of activities that need to be done. We have color coding, and then we also have it, we put it on our calendar. So if it's been done, we give it one color. If it is to be done or is on the calendar, they both get separate colors, and it helps give us a visual. And it also gives us one place where we have to communicate so that if somebody does something, we can all keep track of what's going on. We also use the tools on the SWOG website to keep us up with the expected dates of data entry, and then we share them together as a team. So we also go ahead and for those patients that are on annual follow-up, because I'm sure as everyone knows, once you get to that annual and you're not seeing them so quickly or as in the time period, it gets harder to keep track of. So we make sure that we have a spreadsheet just for that. And then we use the same color coding. The one thing that we have noticed is that the next yearly data point is based on the last date. So keeping track of the last date that we have so that it adjusts to what the plan was is important so that we are not delinquent on that. And then we also make sure that we follow up with the patient, and it helps keep our calendar in sync with the SWOG database. The CRA workbench on the SWOG website has a lot of useful tools that we use. One of our research nurses prints out the expectation and the IPR report at the beginning of each month. And this report lists any upcoming data and expectations and any overdue for the SWOG patients. We can find this under the reports link on the left side of the workbench area. We also use the query report and we print from that and we address any queries that we see there right away. This report lists the queries both for RAVE and pre-RAVE studies. And you can see if you have any queries on the iMetadata RAVE. When we click the SWOG link at the right side of the RAVE homepage, it will show a list of all your SWOG studies. And if there are any query or delinquent data there, it will show as an icon on the page. The other thing that we do is I agree with Sue very much, is we reach out to the SWOG coordinators. Anytime we have any confusion on when something's due or if somebody is in eligibility, we do our best to reach out to them to help take the questions out of it and make sure that we're doing what we need to do. So just communication is key and making sure all of us are on the same page. So thank you very much.
Thank you, Danielle. I think Carol may still be having some audio issues. So Karen and Lorraine, can we move on to you?
Deb, do you want us to go ahead?
Oh, yes, please. Please go
Okay.
ahead. Thank
Okay.
you.
Hi, I'm Karen Miller. I'm the director of the Clinical Trials Office at Feistweiler Cancer Center at Practitioner LSU Health Shreveport. And we're a relatively small cancer center. We are our one key component for our good data quality and query response record is that we are very fortunate in that we have an internal QA/QC coordinator dedicated just to doing that for us. It's Lorraine Post. She's been in that position for about 5 years. And she was our very experienced pharmaceutical regulatory coordinator before that, and went right into the position well. And she's implemented a lot of policies and procedures that have really helped us in the past 5 years. So here she is. She's going to give you some of the key things that she does for our small center.
Hi, everyone. I am Lorraine Post, the QA coordinator for this Feistweiler Cancer Center here. And I was asked to give a brief summary of what I check and how I check it. I'd like to tell you that my job is super easy and that all I have to do is make sure that every patient is eligible, that all data gets entered on time, that we absolutely have no deviations, and we never ever get queried. But we do live in the real world, and we know that that's just not the case. So what I check and how I check it is that coordinators will bring me eligibility criteria and their source documents when we have a potential patient. And I just look to see that everything is matched up, and then I go back to that particular coordinator. We discuss whether or not the patient seems to be eligible, or if there's an issue, why the patient may not be. And then that coordinator will take that to the investigator, and who will then confirm whether or not the patient is eligible. And I do want to stress that I do not confirm eligibility. That is strictly an investigator responsibility. And then once the patient is enrolled in a study and everything has been entered for whatever particular time point comes up, be it the end of a cycle, the end of a report period, end of treatment, death, I get source documents back. I go into the appropriate EDC. And once again, I compare that all data entered has been correct, that source documents that are supposed to be uploaded are indeed uploaded and de-identified. I check consent forms, HIPAA forms, worksheets, questionnaires for correctness, and that there are no blanks in any of the areas, that things are appropriately signed and dated. And then coordinators have provided my feedback as to what I may have found that might be incorrect or what might be questionable. And we discuss the findings, discuss whatever they consider might be questionable. They are always welcome to come to me with anything that they think I may have done wrong. In fact, I'm pretty sure they're happy to do that. But I'm always happy in that respect. Anyway, we're a really good team. We work very well together. I appreciate feedback from them. We learn off each other, and I think that's very important. And I also do encourage, like other people have said, to contact the appropriate data manager for every protocol if there's questions that we just can't answer and don't have the answers to, and to get those responses in writing. And then I try twice a month to go into the EDC. I look for overdue data and outstanding queries, and then forward that to the appropriate coordinator so that they can work towards resolution. And in addition to that, I do quarterly pharmacy reviews, regulatory reviews on a periodic basis, not too often, help prepare for audits, prepare corrective action plans for audit findings, and I participate in study feasibility and deviation committees. Other than that, my job is easy. Karen, anything else?
That's it. That's it for us. We're very fortunate to have her. We're very spoiled because we have the second set of eyes that go over every single thing that we do. So we appreciate we couldn't do as well as we do without her. All right. Are we handing it to Carol or Maggie?
I think we're going to try Carol. Thank you, you guys. Thank you for your presentation. Carol, can we hear you yet?
I think she still has the same problem.
All right. Oh, I'm so sorry, Carol. We'll try to get back to you. Let's forward on to Maggie, who has some audit tips for us. I think there's some behind the scenes unmuting going on.
Okay, Deb, can you hear me?
Yes, thank you,
Yes, we
Maggie.
can.
Awesome. Okay, no problem. It said ask to unmute. Oh, okay. Hi, I'm Maggie. So I'm the NCTM program manager at the Fred Hutchinson Cancer Research Center here in Seattle, Washington. And just want to, before I start, just thank Deb and the entire ORP committee, and also thank Laura Gonzalez from the SWOG QA team for nominating me to be part of this panel. So just want to thank everyone for joining today's session. I just have one slide, and I'm just focusing on a few pointers from a site perspective on some commonly raised items found by the SWOG QA team. And I'm going to be echoing some of the points that Laura Gonzalez just summarized previously in the prior slides. So I'm just going to share my tips and thoughts from a site perspective. Chad, next slide, please. Awesome. Okay. So Laura did touch on some of these from an auditor's perspective. I hope my tips from these from a site point of view will be more so complementary and come full circle. So some of the, so I'm just talking on like 3 points here, and I try to put everything in one cohesive slide. So hopefully this will be easy to follow along. But so first thing I wanted to comment is about access to EMR and uploading any source to you using, for example, CTSU's SDP seems like a very common platform. So if your site's going to be going to enable access to your EMR, it's kind of one of the things that Laura mentioned. It's like begin arranging access in advance with your IT department to ensure login requirements are confirmed prior to the audit. That way you ensure a very smooth audit on day one and no one's frazzled and everyone's just sitting there kind of like tooling with their thumbs. So if you have the ability to have the auditor's login credentials work in advance, that would be great. Whether your audit is in person or remote, if you're granting EMR, consider giving your auditors some sort of tour or orientation of your EMR. Or if that's not feasible, you can also provide them with the SWOG EMR source document locator form. And I've put that link below on this slide that you can find. So it just gives a way to sort of like a directory and tell your auditors like where things are typically stored in your EMR. If you're using something like SDP or similar to upload source that is not ordinarily stored in your EMR, ensure you give yourself ample time to get all those uploaded or staged in advance for your audit team. And just always plan for the unexpected, like unforeseen IT issues, so you can give yourself a buffer if you need to work with IT if you're encountering upload issues, for example. The second item that Laura also talked about was, documenting and furnishing to the auditors the NCI-CRP implementation dates for revisions, updates, or amendments. So if you're, as we all know that with NCI-CRP-led studies, you have 30 days to implement and need to have some way of documenting this. And as she mentioned, it could be something as simple as a log to keep track, like an Excel tracker. What we kind of do here at our site is we have implemented Microsoft SharePoint to track and record all our amendment processing. So we collect dates and store it internally, and if when necessary, we can export this and have this really accessible, ready on hand. And finally, one of the things that Laura also mentioned was about document naming conventions is also another common issue. And probably most people are aware that most of the time, if you're being asked, you're going to be having an audit, whether in person or remote, you're often asked to provide regulatory pharmacy related documents in advance to the lead SWOG QA auditor or to the QA office in advance of your audit. So especially if you will have a large study and caseload, I personally, in my experience, like to ensure all documents being provided have consistent document naming conventions to just make their lives so much easier, so they're not having a huge files to go sift through, and the names of these files are difficult to open, and they realize, oh, that's not what I was thinking that what document would be. So having these consistently named, and I give some couple examples up there, would be really helpful to facilitate their review. One of the things I threw in here, and our experience with remote audits that we encountered this year for the first time ever, is really leveraging SDP and to store documents up there in for accessibility for the auditor. So having them stored in chronological and in consistent manner by date and document type would be really ideal to help the auditors. So as for those who have used or will plan to use SDP, having those audit treatment packets by eligibility and treatment and disease outcomes is like having them ordered in a consistent manner. And if you happen to need more than one packet uploaded, I recommend putting like a cover sheet on top to note what this packet entails. Like if they open this one, this is like cycle 1 through 10, and then the next packet's like 11 through 15 or something like that. So these are just some of the kind of pro tips from a site perspective that we've experienced and had some really good and smooth audit success with the auditors. I certainly welcome Laura if she has anything else to chime in as well to come full circle. But I also wanted to highlight the link. SWOG has a great link on their website for quality assurance and audits. Please check it out if you are not aware of it. There's some great tips and documents and resources there if you are preparing, whether it's your first audit or your second audit or whatever. There's some great tips on that website. So again, thank you for the opportunity, and I'll pass it back to you, Deb.
Thanks, Maggie. All right, Carol, we'll try this one more time. We have a couple of minutes to go back to you if you're available. I see that you're off mute, but I still can't hear you. I think, Carol, I think the best thing to do at this point, because I do know that you have some great input for us, is perhaps to make a slide with a couple of your comments that you were going to make, and then we can upload that with the slide deck as well to the SWOG website. I'm so sorry. I know you put a lot of time and effort into this, and we really want to hear what you have to say. And of course, audio problems, right? It's something that we've gotten used to in the last year and a half. So, but thank you. Thank you to all the presenters and panelists for your willingness to share your experiences and tips with us to help us improve as sites and as oncology research professionals. All right, get ready now for some fun with our next session. It's Getting Back to Basics with Christine Magner, the Data Operations Supervisor at the SDMC. And I want to give as much time as possible to test our knowledge. So without further ado, Christine.
Thanks so much, Deb. First of all, I just want to say bravo to all the presenters and the plethora of tips and information that was relayed. And then also to Deb, I don't know who else could have brought together 12 people to present in an hour and did it almost flawlessly. I mean, so props to Deb. So here's what we're going to do now. By the way, my name is Christine. You can see who I am and what I do, but mostly I am here to help you show what you know. So in just a second, the fine team at IMS are going to launch a poll. And I got to do a poll earlier today, so I'm sure many of you have. It just pops up right on your screen. Use your mouse, select your answers. When you're all done, you click submit. You're going to get 3 minutes to answer 10 questions, and you should know that it's completely anonymous. So when you find out that you got one right, you can cheer yourself on. And if you got it wrong, you can just bow your head in shame and no one will know that you got it wrong. So that's the good news. What we're going to do is once everybody's taken the poll, we are going to go over the answers and kind of see how we all did. So it's going to be fun, I promise. And you're definitely going to learn something, so you can't be mad about that. So if IMS will launch the poll, I will tell you to enjoy the music and we'll see you in about 3 minutes. All right, last couple seconds. All right, if you didn't get through all 10 questions, don't worry, you're still going to find out the answers. We're still going to go through it. And yes, these slides will be available on swog.org in the next couple weeks. So I hope you're feeling good about yourself, about the job that you did. Let's go ahead and go through what we've learned. So the poll results are up. I love that we can see how people answered. Let's see if we can move on with the slides. I'll tell you what, while IMS is getting our slides together, there we go. Thank you. So the first question, and I love to see it trip people up a little bit, the AE assessment date should fall within the cycle, with the final reporting date being, you know, most of these sound pretty good. And I love that we put on there all the correct answers are correct, because that's usually the answer, but not this time, my friends. We were a little bit tricky with this one. We could get next slide. The answer is C. So while yes, mid-cycle you may be assessing the AEs, you may be doing it throughout the cycle, the final reporting date should be at the end of the cycle, ideally on day 1 of the next cycle prior to treatment. That is probably one of the most queried fields we get in all charts, and specifically in the AE form. So if you're doing it mid-cycle and they don't start treatment for another 2 weeks, what's happening in those 2 weeks that we're not getting documented? So that's why we're looking for a final reporting period date to be the end of the cycle, ideally day 1 of the next cycle. The good news is more than half of you got it right. I think another 40% were very, very close. So if we learn nothing else today, that's a great one to start with. Next slide, please. So true or false, withdrawing consent to participate in a study means the patient withdraws consent to being followed. We had about a 70-30 split here, with 69% of you getting it right. The answer is false. If I could get one more click on the slide. Withdrawing consent to participate in a study does not necessarily mean, I'm so sorry. If the patient withdraws consent after registration, the institution must determine with the patient whether they no longer wish to be treated, they no longer wish to be followed, or both. We are sticklers at the SDMC to make sure that this is clearly documented. Withdrawing consent to participate in the study does not necessarily mean the patient also withdraws consent to being followed. This distinction must clearly be documented in the research record and on the off-treatment notice or the follow-up form. Sorry, I'm just looking in the questions. Angela, you asked about question number 1 and the AE assessment date, and you actually asked about 1609. Yes, again, you may assess AEs multiple times through the cycle, but the final reporting period date is what we're looking for. That's what the question was asking for. It should be at the end of the cycle, ideally on day 1 of the next cycle. And again, it was a tricky written question, so I see it stumbling a few people. You may assess disease and adverse events 20 times during a cycle. What the question was is, what should the final AE assessment date be? So hopefully that helps clear up any confusion. And if not, just keep it coming in the chat. But if we can go on to the next question, it was, which of the following actions are required prior to uploading source documents in RAVE? We've given you a lot of really great answers, and to no one's surprise, the correct answer would be all of these. We expect you, as discussed earlier, we expect a fully redacted document, all pages of the document, even if they're blank pages, you'll know they're blank, but we don't know. So either the complete document or a notation that page 4 is blank, so that we're confident we're getting a full report. The SWOG patient number, initials, and SWOG study numbers should be on at least 1 page of every uploaded document. And then I also want to put in there, avoid the unique characters in the name of the document. Many times people will say patient number, or kids call it hashtag, the #. And what that does, that prevents us on our end from viewing these documents. So please don't put special characters in the title. Please also don't put the patient's name in the title of the document. All of these are all the things you need to do prior to uploading your document in Rave. And it looks like 94% of you got that one right. So congratulations. Moving on to the next question, number 4. How can you tell if your study is part of the CTEP AIRS integration? The correct answer, 84% of you knew that. Again, all the answers are correct. You have several different ways that you can confirm this. And everybody did great. Moving on to question number 5. Another true or false, labs should be reported in the units your lab provides to ensure accuracy in reporting. Well, thanks to Jonas, we know that the answer to this one is false. We could get one more click. Labs must be reported in the unit specified on the SWOG form. You're responsible for converting the units. DCs are not allowed to assume or convert. Patients will be made ineligible if the value does not meet the requirement. All SWOG forms will specify the expected unit, and most will also provide an example, such as the one on the slide here. So when in doubt, refer to the form, check the examples, and I think Sue also suggested you could also Google. Was a great tip on maybe SWOG adding a conversion to the CRA workbench, and I think enough good ears heard that to where that will generate some discussion. So thank you for that tip. So how many people got this one right? 72%. So everybody's doing pretty good. Moving on to question 6. When assessing audit findings under the general data quality category, what findings would a major deficiency be assigned to? I think this is a tough question, so thank you for giving it a shot. A, C, and D are all true, so the correct answer is E, and 90% of you got it right. So good job on that. I think, again, I think that was a pretty tough question, so nice work there. I think we can move on to question number 7. If my patient is determined to be ineligible after registration, either by my office or the SWOG SDMC, the patient must not start treatment, the patient must be removed, the patient may start or continue, assuming there is no risk to the patient, or if there's no IND. So which one could this be? Ooh, we have a very divided, if you look at the poll results, very divided. We had about a third say A, we had a quarter say B, and then we had 38% with the correct answer of D. This is very important to note that SWOG operates on the intent to treat policy. If there is no risk to the patient, just because your patient has been made ineligible, either by internal check or by our office, that does not mean they cannot receive protocol treatment. So when in doubt, reach out, you can call and ask, but it's very important to note that just because your patient's ineligible does not mean they cannot either start or continue on treatment. So love that one, that was a good one. Moving on to number 8, we've got a true false. The specimen tracking system should only be used to log and ship specimens for SWOG studies that are being sent to labs. If specimens will not be sent to labs, they should not be entered into the system. The correct answer to this is a big fat false. And if you were on earlier, you heard this actually discussed. The SpecTrack system not only collects information about the specimens that are being submitted to the lab, but also those that are not going to be submitted. It's important to log specimens that aren't being submitted in order to resolve those expectations. If you're on the meeting, my days are blurring together. I think it was yesterday. I believe Phyllis or Kathy mentioned that eventually specimens are going to start affecting your site again, pandemic be darned. So you'll want to keep track of those specimens, not only the ones that have to be logged and shipped, but those that have not been, so that you don't have any outstanding expectations. Because also note that not providing specimens might affect eligibility on some of the studies. So make sure to consult your protocol. Number 9, reporting period start and end dates on treatment form should, and we'll just get to the answer in the respective time. Correct answer is E. It is reflecting the length of the cycle regardless of treatment, and also reflecting the first day the patient received treatment and day one of the next cycle. Again, we discussed a little bit earlier today the difference between reporting periods and treatment periods. So if we give one more click, we have some extra information to provide. Unless otherwise specified in the instructions of the form, reporting periods should reflect the first day the patient receives treatment on the cycle and then extend to the first day of the next cycle. Often, reporting period dates and treatment dates are not the same. So I know that it's hard from a data entry standpoint. You're thinking, why aren't these the same? They should match. They actually really shouldn't in most cases because treatment dates aren't always the extent of the cycle. Hopefully that makes sense, but if you have any questions, you can shout them out. And then question number 10. Who can order investigational agents? Let's go ahead and end the suspense. All the answers are not correct this time. So the correct answer here is B. It's eligible participating investigators registered with CTEP, DCD, TD, or authorized designee. So sadly, I can't see the poll results for questions 9 or 10, but we're going to assume everybody nailed it, did great. If time allows, and I'll let Deb chime in on this, we would love to do another 10 questions or take questions. Deb, you call.
I think we should go with the next poll really quick. We can zoom through the answers. Thank you. I think this is good information.
Can I ask one question real quick, Christine? I got one question.
Yeah.
Just about the source documents. When you say label at least one page, if they upload a packet of 10 pages, can they, just label only the first page?
Absolutely acceptable.
I know that'll make a lot of people happy.
Just one page, that's all we ask.
Thank you.
Let's go with poll B.
I'm working on a quick here on Zoom. Give me a second.
Jad, it's good to know that technical issues happen for the IT specialists as well. Are you saying that Zoom won't allow you to launch the next poll?
Correct. Yes, I'm working on that quick.
Okay.
Give me one more minute. I'm sorry.
Maybe Christine, just because of the timing, so we can get through all 10 questions, maybe you can just take it through the slide, just to leave maybe a couple of minutes at the end for any questions that might come through. If we just advance the slides and do it that way. Oops.
Yeah, if IMS is down, that sounds great.
Would that be best? Oh, do we have it? Oh, okay. All right, okay. I guess we'll do this old school.
Okay, so Site A has a patient who is enrolled and still being treated on SWOG 1234. The patient is relocating to another state, where Site B also has SWOG 1234 open. Site A should. And again, I think we're just going to go advance to the answers. These slides will be available so you can read all the options and see how you do. But for now, all the answers are correct. You basically just want to make sure that there are no outstanding queries or expectations and that everything is in line. Next slide. True or false, I can declare my patient as lost to follow-up on a SWOG-led study if the last contact date from my patient has exceeded 2 years, documented at least 3 telephone attempts to contact the patient, and or a certified letter to the last known address has either been returned or not addressed. Well, that's very wordy. The answer must be true. Next slide, please. Ooh, I'm glad I got that right. That would have been really embarrassing. Just back really quick, to notify the SWOG SDMC that you now have a patient has lost to follow-up and that they meet the criteria as such, use the add event tool on the subject summary page for studies using RAVE. For pre-RAVE trials, you're going to use the lost to the follow-up form available on the CRA workbench under tools of the trade. Next slide. When entering data, if unsure what a form or field is asking for, it's best to, well, I'm going to say my favorite answer is fill out the form with your best guess. If it's wrong, you'll get queried, just like Sue said. But the correct answers are A, B, and C. You want to reach out to the data coordinator via email or telephone, read the instructions on the form, and then the help text that Diane mentioned earlier, available on some fields in RAVE. I just want to mention that both paper and online forms have instructions on them. A lot of times, in order to keep the view simple in RAVE, we leave off a lot of information. So if you go to reference your paper forms, there's going to be a lot more instructions than what you see in RAVE, and they're super helpful. So paper forms still live, they're still important, and we still recommend you check them out. And then personally, as part of the mentoring team for SWOG, I say that doing a few minutes of work up front can save a significant amount of time going back and forth with queries. If you're in doubt, if you can just make a few minutes to call that data coordinator before you start filling out paperwork for studies, can really save a lot of headache, a lot of querying, a lot of time up front. It's what we're here for, is to help guide you, answer any questions, and make sure we all start off on the same track. Rant over. Next slide, please. True or false, once all patients are off study or deceased and all queries have been addressed and resolved, the site may close out the study. Well, the answer there, my friends, is false. It used to be true. It is not true. It is false. We get queried about this often. Please click one more time. Often sites feel that once all patients are off study or deceased, they can close out the study at their site. However, this is not the case with SWOG. Even if all queries have been addressed and expectations resolved, it's likely the study has not yet completed final analysis and or the manuscript has not been written. It's common that there'll be additional findings. We reach out to sites, they need to do a little bit more work. So please, you cannot close out a study with your IRB until it's been added to the list of studies with no required follow-up and or the manuscript has been released. When in doubt, CRA Workbench has your answers. Next question, please. Institutions are considered out of compliance if this percentage of patients registered in the last 13 months is missing baseline data. That's the initial form set. The correct answer here is A, it is 10%. I do want to let you know that it's possible to submit all data and not have expectations resolved. Reasons for this could range from unanswered system queries for a required field, for example, to misnaming uploaded documents. So if the study requires a CT report and you label it as something else in RAVE, it's not going to resolve that expectation. So always check with your expectation report. If you think you've done everything right, just call your data coordinator and find out what's going on. Next slide, please. And next. True or false for expedited reporting? A persistent AE must be reported only once unless the grade becomes more severe in the same or a subsequent course. The answer here is true. Click one more time, please. A persistent AE is one that extends continuously without resolution between treatment cycles or courses. Much like baseline abnormalities, these are only reported once unless it worsens or completely resolves, then returns, meeting reporting requirements. Next slide, please. The appropriate way to respond to a query in RAVE is, I want to point out answer B, change your entry to whatever the data coordinator has asked, is incorrect. The correct answer is C, change the data if necessary and or provide an explanation in the comments field at the bottom of the form. I want to say, when you respond directly to a query in RAVE, it's usually exactly the information we need. However, we need that answer in the SWOG database. The SWOG database will not pull query responses. That's why we ask you to always report in the comments field of the form so that it gets into the SWOG database. It's not because we want you to type the same thing twice. We don't want you duplicating efforts. So resist the urge to respond directly to the query. Put your information in the appropriate comment section. I also want to remind you that at the SDMC, we are not medically trained. So please don't ever just say, what do you want me to enter? Well, I'd love to tell you what to enter, but I don't think that's the most productive way to go about it. Typically, we don't have access to your source docs, so we actually have no idea. We know what we expect to see, but we can't tell you what to enter. So a conversation with your DC will always go a long way. Next slide, please. True or false, unless otherwise specified, only related AE grades 3 to 5, including abnormal laboratory findings, must be reported on the study's adverse events form, the AE form. Well, that sounds legit, right? But the answer is false. Tricky there. Please click one more time. Unless otherwise specified, all grades of adverse events 1 through 5, including abnormal laboratory findings, must be reported on the AE form, regardless of attribution to protocol treatment or clinical significance. Yes, there are studies that only collect certain grades, but generally speaking, it is all grades. Next slide, please. When do you report an SAE on a study that uses the RAVE CTEP errors integration? Tick tock, correct answer is B, within the reporting time frame required by the protocol. Initiate the report in RAVE and links to the CTEP errors integration.
Christine, I am sorry, it is time. We will have these slides on the website. And I am sorry we're out of time for questions. Again, if you do have any questions, please put them in the QA option, and we will provide written answers as well as on the website. And in closing, I just want to give a huge shout out. Thank you to all those involved behind the scenes to make this a successful open forum. Thank you for attending, and we will see you in the spring.